আজকে আমরা শুরু করব ডেভিডসন 976 পেজ হেমাটোলজি। আমরা শুরু করব মাল্টিপল মাইলোমা। This is malignant proliferation of plasma cell. Normal plasma cells are derived from B cell that are and produce immunoglobulin that contain heavy and light chain. Normal immunoglobulins are polyclonal, which means that a variety of heavy chain are produced and each of kappa and then the light chain type. In multiple myeloma, plasma cells produce immunoglobulin of a single heavy and light chain. A monoclonal protein commonly referred as paraprotein. In most cases, excess of light chain is produced. In some cases, only light chain is produced. This appears in urine as Vance-Jones proteinuria and can be measured with serum or urine as free light chain. The frequency of different isotype monoclonal protein myeloma shown box 2558. Classification of multiple myeloma. Type of M protein, level frequency. IgG 55%, so IgG is 55%, most common. IgA 21%, light chain only 22%, others DE non-secretory 2% only. So IgG 55%, light chain only 22%. Although a small number of malignant plasma cells are present in the circulation, the majority are present in the bone marrow. Although small number of malignant plasma cells are present in the circulation, the majority are present in bone marrow. Majority present in bone marrow. The malignant plasma cell produce cytokine, stimulate osteoclast, and present net bone resorption. So the result in light deceleration causes bone pain, fracture, hypercalcemia. Bone pain, fracture, hypercalcemia. Marrow involvement can result in anemia or pancytopenia. Clinical feature and investigation. Incidence of myeloma 4 per 1 lakh, increase per annum, male to female ratio, 2:1. Median age at diagnosis is 60 to 70 years. The disease is more common in people of African Caribbean origin. The clinical feature demonstrated figure 2537. In figure 2537, it's multiple myeloma produce immunoglobulin. In circulation, they call it hyperdissociative. Retinal being the retinal bleeds, bruising, in the heart failure, cerebral ischemia. In figure, we see this ankles retinal vein in hyperviscosity. In abnormal blood test, it can bone marrow, so it can develop anemia, normal macrocytic anemia, pancytopenia, raised ESR greater than 100, usually hypercalcemia, renal impairment, paraprotein, immunoparesis. Vance-Jones proteinuria in urine and serum free light chain, bone marrow, plasma cytoma 10%. Plasma cell in bone marrow, plasma cell count in bone marrow 10%. As it's chronic, so it produces amyloid, and in your panda eyes, nephrotic syndrome. Amyloid causes panda eyes, nephrotic syndrome, carpal tunnel syndrome. As osteolyticlation is causes liticlation, it's called bone pain, fracture, liticlation, eroding right suprapubic and ramus of acetabulum. Skull, this is black region, this is liticlation in the skull. Renal failure, the mnemonic is PINA, P for paraprotein deposition is for hypercalcemia, hyperinfection, and for anxiety and apoamyloidemia. Renal failure due to this spinal cord is compression due to bony collapse and estructural mass. This is the clinical feature in multiple myeloma. And how to diagnosis of multiple myeloma. Diagnosis of multiple myeloma because two of the following criteria to be fulfilled: PML, P for malignant plasma cell, bone marrow, malignant plasma cell, and for M protein, serum and urinary M protein, L for lytic skeletal lytic. So bone marrow aspiration, plasma and urinary electrophoresis, and skeletal survey, investigation required. The latter is classically series of within brain X-ray, but more often a lot of CT scan or whole body MRI is performed. Normally, immunoglobulin levels, the absence of immunophagocytes should cast doubt on the diagnosis. Paraprotein can cause EBT-TSF, but this is not specific. Only approximately 5% present with persistence EBT-TSF above 100. This is significant. Percent 100 ml/hour underlying myeloma. Serum albumin and beta 2 macroglobulin are measured for prognostic purposes. Albumin, beta 2 macroglobulin, prognostic purpose along with cytogenic analysis of tumor. Management. Asymptomatic patient or asymptomatic with no evidence of in-organ damage, example kidney, bone marrow, bone, treatment may not be required. So no asymptomatic no evidence of organ damage, no treatment not to be required. So-called asymptomatic myeloma should be monitored closely for development of in-organ damage. Immediate support, immediate support, high fluid intake to treat renal impairment, hypercalcemia. Analgesia for bone pain, bisphosphonate for hypercalcemia and delete other skeletal related events. Allopurinol prevent urate nephropathy. Plasma therapy is if necessary for hyperviscosity. Antibiotic prophylaxis, liver processing during 3 months of therapy. Chemotherapy with or without hematopoietic stem cell transplantation. Patients are initially assessed their fitness and eligibility for autologous hematopoietic stem cell transplant and treatment pathway vary accordingly. Myeloma therapy has improved with additional novel agent initially. Immunomodulatory drug thalidomide, more recently protease inhibitor, bortezomib, cartilzomib. Second and third generation immunomodulatory drug lenalidomide and pomalidomide, and the anti-myeloma antibody daratumumab, isatuzumab, which binds to CD38 on the plasma malignant cell. Figure number 2538. You can see 2538 figure number. Myeloma plasma cell. Chemotherapy is steroid, melphalan, anthracycline, platinum-based drug. Immunomodulatory thalidomide, lenalidomide, pomalidomide. Proteasome inhibitor, bortezomib, carfilzomib, ixazomib. Targeted antibodies, targeted represent small molecule, anti-CD38, daratumumab, isatuzumab, anti-SLMF7, iltuzumab, histone deacetyl inhibitor, panobiostat. For first-line therapy in older patients who are unsuitable for transplant, thalidomide combined with alkylic agent, melphalan and prednisolone, MFT. Melphalan, prednisolone, thalidomide. Increase median survival more than 4 years. Lenalidomide is the first line for patients not eligible for transplantation who are intolerant for or unsuitable for thalidomide. Thalidomide and lenalidomide both have anti-neogenic effect against tumor vessel. Immunomodulatory effect, anti-immunity effect. Both causes somnolence, constipation, peripheral neuropathy, and thrombosis. Though lenalidomide has a better side effect profile, it is vital that female of childbearing use adequate contraception as thalidomide and granulated teratogenic. Treatment is administered until erythropoietin level have stopped falling. This term plateaupins. It can last for 2 4 years. Younger patients considered eligible for transplant. Standard treatment including first-line therapy such as cyclophosphamide, thalidomide, Davidson CTD, or VTD. VTD means bortezomib, thalidomide, dexamethasone, maximum response, and then autologous SSCT. This improves quality of life and prolongs survival but does not cure myeloma. In all patients who have achieved maximum response, lenalidomide maintenance has been shown prolonged response. When myeloma progresses, treatment is given to induce further plateauphase. UK potassium inhibitor, bortezomib, lenalidomide have been used for second-line therapy as appropriate. However, as they frequent use of first or second-line prognostic benefit, subsequent relapse are more difficult to treat. Pomalidomide, carfilzomib, daratumumab show promise in relapse and refractory diseases. Relatively used patients who respond benefit second autologous SSCT. Radiotherapy. This is effective logical bone pain not responding to simple analgesia for pathologic and for pathological pressure. It is also useful for emergency treatment of spinal cord compression, completing extradural plasmacytomas. Bisphosphonate. Long-term bisphosphonate therapy reduces bone pain and skeletal events. These drugs protect bone, may cause apoptosis and malignancy plasma cells. There is evidence that intravenous zoledronate combination with anti-myeloma therapy confers survival advantage over bisphosphonate. Osteonecrosis of the jaw may be associated with long-term use of oral hygiene. Gum sepsis, regular dental review including check before starting therapy is important. Prognosis, international staging system ISS, ideal prognostic feature, high beta-2 microglobulin and low albumin. At diagnosis, ISS stage 3 median survival 29 months. ISS stage 1, normal albumin, low beta-2 microglobulin. ISS stage 1 have median survival 62 months. Increasing cytological analysis, returning 24, risk patient. Over one third are now surviving 5 years compared to only 1/4 10 years ago. Some general. So this is the end of class.